Surgical demonstration of right-sided cochlear implantation. Patient is a 3.5-year-old male with idiopathic non-familial non-syndromic prelingual profound bilateral sensorineural hearing loss. We start by cleaning the local site thrice with IOPrep, which is 1% weight by volume povidone iodine. After dry mopping the local site, we proceed with marking important landmarks: anteriorly the zygomatic process, posteriorly the temporal line, and inferiorly the mastoid tip. Behind the ear template is placed behind the ear, and the marking for the receiver stimulator complex is done at least 10 mm away from the BTE component. We angle the implant template 30 to 45 degrees with the horizontal posterior superiorly to lie in the relatively flat portion of the skull. Then we move ahead with marking the incision site. Injecting methylene blue to mark the edge of the location of the receiver stimulator complex. This marking guides us when we are drilling the well or recess for the receiver stimulator complex. Infiltrating 3 ml of 2% lignocaine with adrenaline, 1:1 diluted with normal saline in the region of the incision. After marking and infiltration, we move ahead with cleaning the local site thrice with 10% weight by volume povidone iodine. Draping is done and a bag with gauze pads is placed to soak excess saline used during drilling. Ioban, which is a surgical antimicrobial incised drape, is placed, making the incision with a 15 number blade. Subcutaneous tissue and the postauricular muscles are incised, and the dissection is proceeded in the avascular plane. Next, a straight incision is made in the periosteum. Some periosteum and muscle is harvested for later use. The periosteum is elevated anteriorly towards the external auditory canal. Then we elevate a subperiosteal pocket for the receiver stimulator complex. Avoid going beyond the parieto-mastoid suture line. After exposing the surgical site with 2 self-retaining mastoid retractors placed perpendicular to each other, we proceed with the mastoid drilling. Performing a limited cortical mastoidectomy. We collect some bone dust for later use. It is important that we try and keep a bony overhang around the edges of the mastoid cavity and avoid saucerization to prevent unwanted movement of the implant from the mastoid cavity. Here we have reached the mastoid antrum. We start to see the incus through the additus. Before proceeding with the posterior tympanotomy, we thin the posterior canal wall adequately. Performing posterior tympanotomy, we drill in the region of the Herald cells to enter the facial recess. We note that posterior tympanotomy site is bounded anteriorly by the chorda tympani, posteriorly by the facial nerve, and superiorly the incudal buttress and the incus. Widening the posterior tympanotomy site. Using a large-sized diamond burr to thin the posterior canal wall. This helps enhance the light entry into the posterior tympanotomy site. The round window niche is positively identified and confirmed after visualizing the pyramid and the stapedius. Shown in red here is the pyramid and the stapedius, and in the blue circle is the round window niche. Their identification is important as hypotympanic air cells can mimic the round window niche. Then we proceed with drilling the round window niche to expose the round window membrane using a 0.8 mm diamond burr. A small circular or a curette is used to remove bone from the medial aspect of the posterior boundary of the posterior tympanotomy and posteriormost part of the round window niche. If required to enhance the exposure, a sufficiently thinned out posterior canal wall may be outfractured. Tilting the patient's head towards the surgeon allows exposure. Following are the structures visualized during posterior tympanotomy. Marked in purple is the posterior canal wall. Marked in red is the incus. Marked in blue is the inguinal buttress. Marked in black is the pyramid and the stapedius. Marked in yellow is the fallopian canal mastoid segment. Marked in green is the round window niche, and marked in orange is the posterior tympanotomy. Instilling some dexamethasone 4 mg per ml concentration locally and covering the posterior tympanotomy site with gel foam before we begin drilling the recess. Now we proceed with drilling the well or the recess for the receiver stimulator complex. We can appreciate the blue mark caused by methylene blue used initially to mark the lower edge of the well. We can also in this step collect some bone dust for later use. We use the Kirtane retractor under the periosteal flap elevated to expose the site to be drilled. We continue drilling the well with adequate irrigation. We use a cutting burr size 5 or 6 initially and then shift to a diamond burr of the same size for smoothing the rough surfaces. Starting from the edge of the well created for the receiver stimulator complex, we drill a channel towards the mastoid cavity. For the same, we use a 4 mm cutting burr. We should be cautious to prevent injury to the dural plate or the dura. We use a handle template with channel, also called a recess gauge, to check the adequacy of the depth of the well drilled. Irrigating with saline to wash off bone dust. As the channel approaches the mastoid cavity, a 3 mm cutting burr is used to make a tunnel to secure the electrode exit. It is optional to drill tie-down holes, 2 pairs on either side of the channel to further secure the implant. Here, a periosteal elevator is being used on the mastoid cavity side to guard the sudden entry of the burr into the cavity. A 3 mm diamond burr is used to smoothen the tunnel and for final entry into the mastoid cavity. After completing the bony work and before breaching the round window membrane, new drapes are placed and surgeon's gloves are changed. After the implant is opened, the seal of the implant tray is torn open. Confirm the implant is not damaged. Before removing the implant from its casing, a few ml of normal saline is instilled to neutralize the charges in the implant. The receiver stimulator complex is first slid into the periosteal pocket and ensured that it is secure in its well or the recess created. A narrow periosteal pocket is elevated against the bone under the temporalis muscle to lodge the extracochlear electrodes. The intracochlear electrodes along with the sheath is gently slid under the tunnel. The electrodes are held with advance of stillet AOS forceps. A small right angle pick is used to incise the round window membrane. Instilling few drops of dexamethasone and surgical lubricant Helon, which is 10 mg per ml sodium hyaluronate, into the open endosteum. The intracochlear electrodes are held at the flange using the AOS forceps and gently and slowly inserted with as little pressure as possible into the scala tympani. Resistance may indicate contact of the tip with the basilar membrane or the osseous spiral lamina or the vasculature along the lateral cochlear wall. The electrodes are inserted till the first white mark is completely inside and the second or the outer white mark is just at the level of the round window membrane. A claw forceps is used to hold the electrodes and secure it in position. Periosteum collected initially is used to seal the round window membrane, and the muzzle is used to seal the posterior tympanotomy site. The bone dust collected previously is used to reinforce the posterior canal wall fracture site. Next, placing a piece of Surgicel between the electrodes and the posterior canal wall. Placing pieces of Surgicel in the mastoid cavity. Surgicel is used as an additional support for the electrode array to be in position. Placing some bone dust in the region of the tunnel and the channel. Positioning the extracochlear electrodes in the pocket made previously under the temporalis muscle. We close the incision in 3 layers: periosteum, subcutaneous tissue, and skin. Here we are closing the periosteal layer with simple interrupted sutures using 3/0 vicryl. Subcutaneous tissue is sutured using 3/0 vicryl. After closing the subcutaneous tissue, we attach the external processor to check for impedance and obtain neural response telemetry (NRT). Impedances were sufficiently low in all electrodes, and NRT was obtained in all 22 electrodes. Skin is closed using foromonocryl or nylon. Steri strips are placed along the suture line and regular mastoid dressing is done. On day 3, mastoid dressing is changed and X-ray is performed to check the position of the electrodes. If skin is sutured using nylon, sutures are removed on day 7. Switch on of the implant is planned 2 to 3 weeks after. Modified Stenver's view of the mastoid showing electrodes within the cochlea. Thank you for watching.